epidemic has gone up. We've seen that same thing in neonatal abstinence syndrome, and there were places that if you go back 10 years ago, who really had very small amounts of this, and I don't think there's any place that doesn't have a problem with this anywhere in the country. Some of the leading places are mostly in New England and in West Virginia, Tennessee, Kentucky. There are counties in West Virginia where 10% of the babies born have NAS. So there's lots of it. This is growing. It's tends to take up lots of beds in ICUs and has very, very long lengths of stay. The average lengths of stay, it's hard to know exactly where we are now, but it tends to be somewhere around 3 weeks. And often it's there in the past, it often was much longer than that, but the average has been about 3 weeks. And a lot of neonatal ICU beds are taken up with babies with neonatal abstinence syndrome. In this study, it was about 4%, but in community hospitals, as high as 50%. And that's certainly what we've seen in Connecticut, where our community hospitals are mostly taking care of babies with neonatal abstinence syndrome, or NAS. So what happens to the baby? When a fetus is inside the mother, they kind of get whatever the mom's taking. So if the mom is in a methadone program, which is most common in our area, then the fetus is seeing the methadone on a very regular basis. And so there's changes in the brain, particularly in an area called the locus ceruleus, where in order to keep a level of homeostasis, they'll upregulate all these norepinephrine receptors. And so once the baby's born and they're no longer seeing the methadone, they have all these extra receptors, and there's this overabundance of norepinephrine, and that seems to coincide with the withdrawal signs. And the withdrawal signs are really, similar to what you'd seen in an adult. And I'm not an expert in addiction or withdrawal or adult stuff, and most of what I know from that comes from watching The Wire or the movie Trainspotting, which both are excellent. If you haven't seen those are great. If there's no other takeaway from this talk, you should see The Wire. It's great. And that has been, this is not a new phenomenon. The first papers on neonatal abstinence syndrome, it wasn't called that then, come from as far back as 1890. And there's the first, sort of review articles in the 1950s. And what you saw back then was there was a high rate of mortality. And a lot of that was what was reported. The mortality cases were reported, but there was quite a bit of mortality with it. And then when methadone came in as a treatment with MAT treatment, that started to help things. And really the big changes in the care of this were in the 1970s with Loretta Finnegan and the work that she did. In Philadelphia, they were in the midst of an opioid epidemic, a heroin epidemic, and her NICU was really over. They were seeing tons and tons of babies going through withdrawal, and so they were looking for a way to standardize things. And of course, they developed this tool that everyone knows pretty well. And this is just a version of the Finnegan neonatal abstinence scoring tool. And this was really a big deal at the time, and in their original studies actually reduced length of stay. And what this was, after seeing all these babies, they really were able to see all the signs of withdrawal that you might see. And this is a pretty exhaustive list, and there's 21 items. This is considered the modified version. It's not that modified. The area that is excoriations used to be built out a little bit more, so it's excoriations in different areas. So the major modification is just making that one area. And so I'm sure most of you, if you've taken care of any babies with this, are quite familiar with this. It's broken down into central nervous system disturbances, metabolic, vasomotor, respiratory disturbances, and gastrointestinal disturbances. So, and then it's given a point value, and there's not a ton of science behind the point values, but things that seem worse were given a higher point value. So if you have severe tremors when you're disturbed, that's 3 points. If you have mild tremors, it's 1 point. If you have things like sweating, it's only a point. And again, things that seem a little bit worse that can be a little more severe will give it more points. And then the way you would use this tool is you would assess babies on a regular intervals, somewhere between usually 2 and 6 hours, depending on your place and how the baby's doing. And then what you do is you add up the scores, and there's a magic number that I'm sure if anyone is taking care of these kids, that you are saying silently in your head, which is 8. And so it's usually 3 scores of 8. Some places 2 scores of 8. Some places will be 3 scores of 8 and 2 scores of 12. So when you're managing these babies, you're looking at those scores, and if you get over that whatever that threshold is, which again tends to be 8, you start medication. And speaking of medication, so medication, like the way that babies have been treated with this over years has been pretty consistent. The first line treatment is non-pharmacologic interventions, and then second line is medications. And so much of the research over the years has been trying to figure out what the right medication to give these babies, and or combination of medications to help them through this. And the outcomes have usually been looking at either the length of the treatment of the drug or the length in the hospital, which again are quite long. And so this is where that's the background. I'm going to sort of start our story of what things look like at Yale in Connecticut. And we are, New England has been on the forefront of NAS for many years. We're Connecticut's sort of New England state, so it hasn't been as bad as places like Maine and Vermont and New Hampshire, but we've always had our share of babies. And so when we, in the 1970s, we were treating babies with this medication, which is paregoric, which certainly doesn't look like something you would want to give to anybody, but paregoric is a tincture of opium, which means there's 30% alcohol. Then I also mix in a couple other things that are, several of which are carcinogenic. So it seemed like an interesting choice. I'm not sure why we went that way at the time, but that was pretty quickly switched to just tincture of opium. And I'm going to you'll see a couple of references on the bottom, which are these studies that were comparing the drugs. And this was one comparing tincture of opium and morphine and finding basically the same length of stay. So we moved over to tincture of opium. In the 90s, we actually switched over to morphine. And the reason we switched over to morphine was really because our pharmacy stopped carrying tincture of opium. So it wasn't really a management decision, but it was pretty similar, and we could use the same things. And this study is actually listed on the bottom, is from Scotland, where they compared giving morphine versus giving phenobarbital as the treatment. And so what you'll find in the AAP guidelines, and from most guidelines, they'll say you should use a like medication. So if you're withdrawing from an opioid, you should give an opioid. And phenobarbital, of course, isn't an opioid, but tends to be more of a sedative and can calm down some of the signs of withdrawal. And so this is using it as a first-line agent, which you still see in a fair number of places around the country, but more often it's used as an adjuvant therapy. And this is speaking of that, this is a study from Rhode Island, from Brown, which was a really powerful study. They did a trial where they gave half the kids tincture of opium and half the kids right up front tincture of opium and phenobarbital. And they saw that the group that got the phenobarbital and the tincture of opium, they had half the length of stay of the group that just got tincture of opium. So an incredibly powerful result. And if you look at the Cochrane Review articles, I'm sure people have seen Cochrane Review articles in the past. They're kind of the system of review articles, and they go through the literature, and they give a conclusion at the end, and every one of them that I have read, the conclusion is I need more studies. The only exception was the NAS one, which said, based on this study, this is what people should be doing. I've not seen a lot of people actually using this approach, but this is actually what that Cochrane Review around that time recommended. And more recently, there's been studies comparing morphine and methadone, and this is a study from Maine, which I always enjoy saying because I don't think people get to say that very often because there's really not that many people in Maine, but they had enough to do those who were there. There's quite a few NAS babies. So they gave half the kids morphine and half the kids methadone and found there was a lower length of stay in the kids who got methadone. Clonidine has been another medication used as an adjuvant therapy occasionally, and Johns Hopkins was the first to really do an extensive study on this, and they did that the first was reported in 2006, and they gave half the kids tincture of opium and half the kids tincture of opium and clonidine, basically the same model as what the study of Brown had done, and they found that the kids who got clonidine had a lower median length of stay. And this was based on this. We actually started using clonidine. So I am actually not a neonatologist. I'm a pediatric hospitalist, and I started in 2006 as a hospitalist at Yale. I'd been a resident here before then, and what we were doing, we were starting on babies on morphine and clonidine at the time. My predecessor had started that, and so if we look at the standard approach, we can see and I'll go over how we're doing it at Yale. So basically, there's 5 elements of the standard approach. One is medications are the key to treatment. If you read a lot of these studies and a lot of the way people think about this is that often people won't consider a baby to have NAS unless they're given medication. So that's really the key to treatment. Most of these babies are managed in NICU. There's quite a bit of variability around this and a little more these days between NICU, regular newborn nurseries, pediatric floors, and even at home. And so those are really the 4 major places, but NICU is kind of the mainstay of management of babies with neonatal abstinence syndrome. Finnegan scores are the kind of the key to treatment. They are what is used, or some version of it is used by the vast majority of places. A study in the early 2010s had it about 95% of places were using the Finnegan tool. There's been a lot of efforts to find simpler versions of it that don't have quite as many items, but have the same specificity, and a lot of them have been successful, but nobody really uses them. It's all sort of Finnegan related. Medication dosing has been pretty standard. Most places will start, they'll have their starting dose and then wean by usually 10% every day or every other day. And then kind of with the NICU model, the focus has really been on the staff caring for the babies. One of the big, I always get nervous when I'm being a resident here, an audience of neonatal nurses always makes me nervous, because I remember there was that one time where I examined a baby without asking permission, and I don't know, that was like 20 years ago, but I'm still slightly scarred from it. So the NICU staff is really, it's one of the benefits of being in a NICU is those nurses, they own those babies, they take care of them like they're their own. And so that's kind of the standard 5 pillars of how NAS is managed. At Yale, we did something very similar. There's some slight alterations. One, when babies were born that we knew were exposed to opioids, they were taken from the delivery room to our NICU and put in, like a bassinet or an isolette, monitored closely with the Finnegan scores. And as soon as they got 3 scores of 8, they were started on morphine, or morphine, more commonly in the beginning, morphine and clonidine. And then the issue that we had that was a little bit different for us is that at the time, our NICU was a little bit smaller than what our needs were. And so they were looking for babies that they could transfer out. And what they decided on this population. So after an average of about 7 days, when the NICU felt like they had stabilized the dose of morphine, then they would transfer the babies up to the pediatric inpatient unit on the 7th floor where I worked, and that's where I started in 2006. So we were getting these babies then and just continuing with the protocol of weaning the morphine by 10% every other day that the Finnegan scores were below 8. So you had to have 2 really good days before you could go down by the 10%. And so if you have that kind of protocol, it's really hard to have a length of stay that's much shorter than 3.5 or 4 weeks, which is what our length stay was. Our average length stay was about 4 weeks. And then in the NICU, it was the staff takes care of the baby model. On the floors, families could stay. They weren't really encouraged to. They were allowed to stay. It happened very infrequently. I can remember the 2 families over the 3 or 4 years that we were caring for these babies before we started to make some changes that actually stayed. It tended to make, the nurses felt it made their life a little bit harder. They didn't get along well with families, and so the less time they were here, the better. And so that was kind of our management plan, and that not too different from kind of a standard plan. I don't know if any of that sounds familiar to anybody in the audience, but probably at least pieces of that do. That's generally what we'll see. So We'll take a little quiz break just to make sure everybody's alert and awake. So, so what you have here is, this is going to be a little game that you're going to play on your computer screen. So there's 9 dots here. What I want you to do is to connect all 9 of these dots using 4 lines without taking your finger off the screen. So 4 lines, can't take your finger off the screen, connect all 9 dots. And I'm going to give you, 30 seconds or so. If you know how to do it, just kind of look smug. Oh, somebody's actually writing on the screen. That's very cool. One, 2, 3, that's 5 lines. Got to do it in 4. 5's easy. Okay, you do it in 4. All right, here's the answer. You ready? Well, that's not it at all. That's 3 lines and you didn't connect everything. Okay, here's how you do it. So, so that's, you can see there's 4 lines. 1, 2, 3, 4. And the idea here is that you have to, in order to do this, you have to actually think outside the box. And I'm sure everyone knows that saying, but it actually comes from this game, the saying, thinking outside the box. And I always thought thinking outside the box, the idea behind that was, everybody's thinking about something over here, whether the answer is 2 or 3. And when you think outside the box, you think, no, it's actually purple. And you're thinking about something totally different. It's not actually what it means. The idea of thinking outside the box is realizing that it's not a box. So if you go back to this, I don't know how to get rid of the drawing, but if you look at this, it's not actually a box. It's 9 dots, and the box is something we make in our minds. So we create this box. We create this rule that you can't go outside these lines because it's a box, even though it isn't. And so that's really important, and that's a really important thing in medicine, because what we tend to do is we create these rules that somebody just says something once and we make it a rule, and we get very nervous deviating from it, even when we know or think that maybe it doesn't make a lot of sense. And so we create all these boxes. And what we found when we started to look at how we were managing neonatal abstinence syndrome, we were dealing with a lot of these boxes that were really made up rules. We had to really look out for these boxes and figure out where it was something that was meaningful and something where it really wasn't. So I don't know how to get. I think we're going to have those lines here for the rest of the time.
Yeah, somebody put that on there. I don't know if you can take it off. Would be good.
Put it on. Whoever drew that one.
This is new to me.
Me too, but otherwise we'll enjoy the background.
Yes.
That's also fine. So, so looking at our data at Yale, as I mentioned, from 2003 to 2006, this was a time when I was a resident, our length of stay for these babies was 28 days, which was not too far from the norm. And there's lots of places that had longer lengths of stay. As a hospitalist, so how did I end up? Oh, thank you, whoever did that. So I took over as a pediatric hospitalist when I finished my residency in 2006, and that we had just started a hospice program the year before, and there was a guy there that was who started. I was replacing somebody who was there for only a year, and I was replacing him. So the guy who'd been there a year got to choose which floor he wanted to work on. We had an infant toddler floor, and we had a school age teenage floor, and he chose to work on the school age and teenage floor, and he gave 2 reasons. One was that he didn't want to take care of these babies, and 2 was that he liked teenagers, which nobody believes, because who likes teenagers? That doesn't make any sense. But we did believe that he didn't want to take care of these babies, because these kids, we would take care of these. We're used to, as hospitalists, we're trying to get people in and out of the hospital, not keep people in the hospital longer than they need to. Our length of stay is often averages about 2 days. And we were getting these kids at about day 7. So we were keeping them for 21 days, which was so much longer than anything else we were doing. It would drive us crazy. And there wasn't much to do. My predecessor used to actually, so what we would do on rounds is you would sit, we now do family-centered rounds, but we didn't then. You'd sit around a table, and you talk about the patients. And for these, the resident would present the Finnegan scores and the weight, and then we would say go up or down on the medication, and that was it. You didn't need to do anything else. You didn't need to really see the patient. It didn't add anything. They were kind of miserable. The nurses would be carrying them around, doing the best they could. And that was it. And so it was kind of frustrating. It was frustrating dealing with the families a lot of times. And so it wasn't anything anybody really was looking forward to taking care of. So he managed to get out of it. And so I got stuck with it. My predecessor used to take the Finnegan scores at the end of the week and play the lottery for the resident team to keep it interesting. I was much too cheap for that, so I didn't do that. But it was just not something that there was a lot of interest in. It's not something I paid a lot of attention to when I came in. I was trying to learn all sorts of new things on the job. And this was something I didn't need to learn a lot about because we had a really nice protocol that was developed by a lot of senior people in the NICU that told us how we were going to manage these kids and how we were going to wean them. So I just needed to follow the protocol and not really worry about it. Now, there was a thing that was a little bit that I just couldn't quite stomach, was this every other day weaning of morphine. You know, you'd have this kid who was doing totally fine, and we'd go down by this tiny amount in the morphine, and the next day he would still be doing totally fine, and we wouldn't be allowed to go down. And so we just sort of fudged that part of the protocol. We didn't tell anybody. We just kind of just said, okay, we'll do every other day, which is certainly not radical. That's what most places were doing. Not that I was aware of that at the time. So we just kind of did it and didn't worry about it. Now, so somehow one of my colleagues looked for this data. I certainly didn't see it. It wasn't something we were trying to do, but we had reduced our length of stay from 28 days to 22 and a half days, not on purpose, really. And that is, if you have that kind of decrease in length of stay in like any other disease process, that's a huge deal. And so he was, my colleague was moonlighting at a community hospital up the road called Middlesex Hospital. It's about 45 minutes away. And they asked, their length of stay for these babies was about 6 weeks. And so they wanted to know what amazing things we were doing at Yale to get such a low length of stay. And they asked if I would come give a talk. And so we're supposed to say yes when people ask us that stuff. So I had to say yes. And I had to go there and I had to prepare a talk. And when I started, I had about 90 seconds of material. I had our protocol and I had the thing about the lottery. And that was it. And so I had to start reading all of the articles that I had shown before. When I did that, I found something kind of funny. So I'm just going to list all of these medication studies. So you have DTO is diluted tincture of opium. So you have diluted tincture of opium versus tincture of opium plus clonidine. That was a study from Johns Hopkins. The median length of stay of treatment was 17 days versus 12 days. Morphine versus phenobarbital, it's a study from Scotland. The treatment days were 8 days versus 12 days. Morphine versus tincture of opium was 30 days versus 27 days. Tincture of opium versus tincture of opium plus phenobarbital. This is a study from Brown that the Cochrane Review thought was the greatest thing. It was a randomized control trial. Length of stay was 79 days to 38 days. I say that again, 79 days to 38 days. So the length of stay was half, but it's still the longest length of stay on the board. Methadone versus morphine, this was the one from Maine, 17 days versus 24 days. We're still doing these studies. 2 years ago, there was a study published in the New England Journal of Medicine that compared treating with morphine versus buprenorphine. The morphine group had a length of stay of 33 days, the buprenorphine group, 21 days. Now, if we look at these, now what's nice about this population is there's not much of a past medical history. There are newborns that were just born. The exposures tend to be fairly similar or controllable. And the protocols are basically the same. They're kind of what we talked about. There's all those 5 pillars of them. And so you would expect things to be pretty similar. Yet, if you look at the places that treated with tincture of opium, you have a length of stay that ranges from 17 days to 79 days. With morphine, you have a range of 8 days to 30 days. And if you include the New England Journal, it's actually 33 days. That is an incredible spread for things that are very similar. And you do not see that. I defy you to find another disorder that has anything close to that. It doesn't make any sense. It's crazy. And so, and looking at that, I thought, God, what is the, why could this be? Why is this? What's going on? And of course, the answer was that I had no idea. But I thought maybe it wasn't really about the medications. So if you look at the AAP guidelines, if you recall, I mentioned that the standard of treatment includes a non-pharmacologic interventions first, And that's absolutely what the AAP says. And they spend 56 words talking about non-pharmacologic interventions and 1,652 words on pharmacologic interventions. So yes, non-pharmacologic interventions are the first line treatment, but it's not something that's been thought of as kind of a real treatment. I think about neonatologists who are putting people on ECMO and taking care of these impossibly premature and small babies and saving their lives and doing all these incredible interventions to save their lives. The idea of holding a baby and bouncing them as real treatment, it doesn't really pass the laugh test, I don't think, for most of these intensivists. These are intensive care doctors. It's something you're supposed to do, but it's not really. It's like, yeah, we do that kind of thing, but it doesn't feel very doctory. It doesn't feel like a real treatment. And if you look at these papers, it's pretty amazing. Most of them, some of them don't mention the non-pharmacologic intervention. Some of them say, yes, we did non-pharmacologic interventions, but none of them control for it. And so you didn't know if the mom was there, if they were holding the baby all the time or anything like that. And so if you think about it, I kind of think about it the other way. So remember, the first line treatment is listed as this. So let's say you wanted to actually study the first line treatment and wanted to study, say, swaddling and the effect of swaddling. And then you just said, yeah, I don't know, some of the second line treatment was morphine, and some of them got it and some of them didn't. I didn't keep track of who got it. No one would ever publish that paper. They would laugh you out of the place. But if it's non-pharmacologic care, then it doesn't really matter that much. It's not that big a deal. Even though it's listed as the first line treatment, which I imagine if you think back of all the protocols you've had, I'm sure that was listed as the first line treatment. So back to our story at Yale. So when we started from 2003, we really started working on this in 2010. So we had 150 babies from 2003 to 2010 who were exposed to methadone. And for our study, we looked at the methadone exposed kids, which was about 90% of them, just because we knew on average, those were the most consistent and most severe withdrawal. So the numbers are slightly better if we include everything. So here we 98% of our babies were treated. There were only 2 that were treated with morphine. If we included all babies, it goes down to about 96%. But basically, but from now on, I'm just going to talk about the methadone kids because it's more consistent and it's easier to know who to include. So 98% of these babies were treated with morphine. That means 98% of them had 3 scores of 8 or more. And so we thought, okay, let's start to look at this and see if we can think about how we're going about this and if there's a way we can maybe make this go better. So I'm going to present our data going forward in a control chart. And so and the idea behind this, let me just orient you to this. Oh, let me see if I can go back. Each yellow dot is, sorry, on the x-axis is the date, and we're going from 2008 to 2010, and the length of stay is on the left side, and we go as high as almost 70 days. So each yellow dot is an individual patient and their length of stay. The black line is our average length of stay, which at this point was 22.5 days during this period. And the green line is the results of the biggest quality improvement project on this topic, which was run through the Vermont-Oxford network, which I'm sure some of you are a part of. That they looked at 199 institutions and tried to improve the length of stay in these babies, and actually reduced it by 2 days across 199 hospitals, which is an enormous change. The number of hospital days that decreased is an enormous amount. So it's a very impactful study, and that's the biggest, and that's a successful study down to about 19 days. The red lines are what we call the control limits, and they're basically 3 standard deviations from the mean. And so the way to think about that is trying to be predictive of your next point. So we would say that if we had a baby born with opioid exposed, we could expect that their length of stay would fall somewhere between the red lines, which in this case was 0 and 47 days. So not that helpful. And that just tells you there's a lot of variation in your length of stay. And so if you're trying to improve length of stay, you want 2 things to happen. You want that the mean, your average line or the black line to go down, so your average decreases, and then you want those red lines to get closer together, so it's a more stable and predictable process. I would say that our goal setting out wasn't really to reduce length of stay. It was really to have this go better for the baby and the mom. And that was really what we were thinking about. Okay, so quality improvement is a really great way to approach this. It's a trial and error kind of approach. You use these PDSA cycles where you plan a little study and you do it and you study it and you decide whether you want to keep it or not. And it basically is looking for ways to improve mostly on the current system. How can you tweak things to make it better? And the study I've listed below is a study from Ohio, and there's really nobody who does quality improvement in pediatrics any better than the folks in Ohio at Ohio State and Cincinnati. And this study, they basically took the standard approach and really just did their quality improvement job on it and made sure that every aspect of the normal traditional approach was done perfectly. So everybody who was giving a Finnegan score, their interrelated reliability was really high. They were following their protocols perfectly. They were weaning as quickly as they could based on these protocols, and they got their length of stay down dramatically from the mid 30s to the low 20s. Really something. But that's still so low 20s is still the longest length of stay of anything in pediatrics outside of prematurity. So if you look at any of these disorders that we have, none of them have a length of stay. Your severe pneumonias with chest tubes, empyemas and chest tubes, they don't have a length of stay anywhere approaching the length of stay of kids with NAS. So they got it. They did a great job. They improved it. So it's still the longest length of stay of anything in pediatrics. So it reminded me of this sailboat. This is the Thomas W. Lawson. I don't know anything about sailboats, but this was built around the turn of the 20th century. So in the early 1900s, and this is actually an oil tanker. And so it's also the only 7-masted sailboat ever built. And the first response, oh, that's impressive. And so you always have to wonder if it's the only one ever built, why weren't more built? So it was this was at a time where steamships were coming into play, and so steamships were faster, they were more efficient. It was kind of a better model. And so if you were a sailboat builder, you had a choice: is you could entirely change your paradigm over to steamships, or you could try to improve your sailboats as best you could. And that's where the 7-masted sailboat came in. Problems, it took up a lot of space. There was less room for the oil, and it was very difficult to maneuver. And so after about 3 months, it ran aground and sank. And so that was the end of the 7-masted sailboat. And so a lot of quality improvement is building these 7-masted sailboats, is taking an idea that maybe doesn't work as well anymore and just trying to improve it. And that's basically thinking about, going back to our analogy about thinking outside the box, it's taking these boxes and saying, okay, we have to do it this way. We just have to do it this way as well as we can. And that's kind of what they did in Ohio. They did it very well, but we thought maybe we should try to build a steamship. So what we did is we looked at our standard approach that we were doing, and we just started to simply ask, why were we doing it that way? And we went back and tried to find the reasoning behind it. We knew that we were doing what we actually found out is the reason we were doing what we were doing today is because that's what we were doing yesterday. And that was really it. And we went and tried to uncover, where did this come from and where's the data behind this and why does this make sense? It was really troubling because there really was very little there. So I'll take you through each one of those 5 elements of the standard approach. So first, medication. So why are medications the first line treatment? Okay, so not surprisingly, when we looked, we found this study that came from Vancouver, where they did this kind of crazy thing. They took the baby and they took the mom and they put them together. And it was one of those ideas that was just crazy enough to work. And what they found, not surprisingly, is that babies tend to like their moms, and moms tend to like their babies. So it shouldn't have been that groundbreaking, but it was a big deal. And so instead of separating the mom and the baby, they put them together, they cared for them together, and they found really good results. And we thought that made a lot of sense. So in the midst of this, we said, okay, we were looking at the data about the medications that if it wasn't really going to be about the medications, then why didn't we just, try to do the non-pharmacologic care better? So this is really the start of the least innovative improvement project. because we just essentially, this is what the guidelines say to do, is to do non-pharmacologic care. So we thought, why don't we actually really do it? So one of the advantages that we had on our inpatient unit is that we could control the environment a little bit. We could actually deliver a lot of these non-pharmacologic interventions. So we were encouraging the parents to stay. We were controlling the environment. We were feeding the babies on demand more. And we found that there was a decrease in our length of stay from 22 and a half days all the way down to 13 days, 13.2 days. And so if we had a medication that did that, that is the medication that we would be using on everybody. But it wasn't. And so what was the actual, what could we bottle out of this? What could we look at as the medication? And you can also see, you look at the red lines have gone down. So we can expect that the next baby is going to stay somewhere between 0 and 29 days with some certainty. So this was really interesting, and we were just, again, doing what we were. There was nothing new in this. It was just doing it aggressively from the beginning, and making sure the parents were there. So when we thought about it a little bit, we thought, okay, wait a minute. So what's really happening here? What are we doing differently? And so there's a lot of things that we could do as a staff, where we can control the environment a little bit. You know, we have the ability to do that, but there's some problems with feeding on demand. I don't know if anyone has heard this said, when you have a baby, that they're not due to eat yet. And so that is something we hear in the hospital all the time. That's not a real thing. So I don't know if any of you have had babies before, and if you looked and said, like, well, the baby seems really hungry, but we got 15 minutes more to go until it's the 3-hour mark, which is when I've decided we're going to feed this baby. You probably, now maybe some of you would be like, no, that's how we do things. But most of you probably would say, like, oh, the baby's hungry. Why don't I feed the baby? And so it's not something we did. And so you had a 3-hour schedule, and you fed the baby on a 3-hour schedule. And part of that is because if you're a nurse and you have 5 patients and you're trying to feed these, so many times these babies need to feed every 45 minutes or so. They have a lot of extra losses going on. They're using a lot of energy. They sometimes have trouble feeding. It's also soothing for them. So sometimes they need to feed all the time. And if you're a nurse and you're the one responsible for feeding the kid, you can't do that. You have to do it on a schedule because you got other things to do. If it was your only patient, you could do it, but that's not how this works. So there was that part of it. And there was also when the baby might be calm, and then they start to cry, and they get upset, and then all of the withdrawal signs start to snowball. And I think all of you have seen that happen as well. And so one of the things we found could be really helpful is if once that starts, instead of, if you're the nurse and you have to be the one to go in there, that you got to give medication to those 2 kids, and then you can go in and help that baby. And so by then things have gotten a little out of control. If you could respond within seconds, sometimes you can short circuit that. But who's around to do that? Nobody. Well, it turns out if there is somebody, those last 2 things, who could do those things, and it has to be a parent or family member or somebody at the bedside who's caring for the baby, who's not part of the medical staff, who can be there all the time, who can feed the kid whenever the kid wants to be fed, who can hold the kid as much as the kid wants to be held, even if that's all the time, and can feed them as frequently as they can respond immediately when things happen. And so it was really, what we saw the difference was having the parent there. And it's almost always the mom. I'm going to say mom. Sometimes it's the dad. Sometimes it's somebody else in the family. Most often it's the mom. So we thought, oh my gosh, this is really about the mom being there. And so this is where we came up with our first really like pillar of how we think about treating these kids, and is that mom is medication. So imagine, so that mom is the antibiotics for pneumonia. Mom is albuterol if you have asthma. That we have to think about it in those terms. And that's the first one. So mom is medicine. So we started to think about it. If you start to take that approach, and this is where the box things come in. Well, these kids all went to the NICU. They had to go to the NICU. And so, well, and what are we going to do? We can't do those. We had one of those cafeteria style NICUs. Here's the website, the old website photo of our NICU. It's one of those ones where you have 12 babies in the room. There's a lot, it's bright, it's loud, it's bustling. There's a million people around. This is where I actually snuck in to take a picture. You can see there's no place for the family to sit. There's like that, you can see that rolly chair with the tape on the arm. Not the most welcoming place, not a calm place. This is not, if you think about those elements of non-pharmacologic care, having, these babies are hyperstimulated, having a calm environment that's low stimulation, being able to hold them and swaddle them calmly, to feed them on demand. You can't do any of those things in the NICU. You can swaddle the baby and you can feed them on your schedule, and it's going to be loud and it's going to be bright, and there's nothing you can do about that. So so it's sort of the worst environment, and you can't, if you're a parent, you can't stay. There's a place to sit, but the mom's, in the beginning might be admitted to the hospital. She might have had a C-section. You can't, you're not even welcome all the time. If we round in the middle of the room, the families aren't allowed during that time. It's very unwelcoming for families. So it's a place that, the way that we started to think about it, okay, wait a minute, if we're sending these babies to this unit where there's no mom, that would be like taking an asthmatic, and when you had 2 units you could send them to, and you have 1 unit where they don't carry albuterol and one where they do, and you had to decide where to send them. Or if it were pneumonia, oh, this unit doesn't carry any antibiotics. You have to just treat them in other ways, and this one does. It's sort of a silly, you wouldn't, I mean, it's sort of a stupid analogy, because who would ever do that? But that's exactly what we're doing with these babies. We were taking the first line treatment and ignoring it, because these babies had to be in the NICU. And why do they have to be in the NICU? Well, because we brought them there yesterday. So if you look at our inpatient unit, it's certainly not that nice up in the inpatient wards, but we do have a lot of single rooms or double rooms where 1 or 2 family members can stay. There's a refrigerator in some of the rooms. They can move in, they can settle in, they can stay there, and they can be there all the time. They can control the environment. They can be with their baby at all times. The mom and the baby can be there together. So we said, okay, we can't, why would we send these kids? Why are these kids going to the NICU? Why is this happening? So it's been happening forever. It happens at every place. What is the reasoning? Because they're going to an intensive care unit, and these babies do not need respiratory support. They do not need lines of any kind or any support in that way. So why are they going to an intensive care unit? And you can ask yourself, I'm sure some of you are taking care of these babies in intensive care units. So what's the reason? So here's the reasons we've heard. Well, the main reason is because, well, it's where they've always gone. The second that we would hear sometimes is, well, they might have seizures. And so there's a couple of answers to that. It's one, okay, so so if in our institution, if you were 2 days old and you'd gone home and you had a seizure, you would come back and you wouldn't go to our NICU, you would go to our neurology unit, our seizure unit. And so that would be if you had seizures. Second, we don't usually put people in intensive care unit because they might have a seizure. There's a lot of people with epilepsy who might have a seizure, or people who might have febrile seizures, and we do not keep them in ICUs. Most importantly, when people cite the risk of seizures in these babies, they will talk about a study from the early 1970s where it says 2 to 11% of these babies will have seizures. And that's a big number. And the reason that everyone cites that study, it's also a pretty big spread, 2 to 11%. People cite that study because it hasn't been replicated. Nobody else has really found that. And so we actually, one of the authors of that study, he just retired from our system. And so we asked him about it, and his answer was, well, we weren't really sure if those were seizures. We have not had any seizures in the time that I've been here with these. It certainly could happen, less likely with opioids and much more common, I would think, in an older population, at least with benzos. But this has not been an issue. So there's really, that is the reason to keep these kids in an ICU, and it's not a good reason. There are really no other reasons, and the rest of the intensive care units are great, but not if you don't need intensive care. And these kids need a different kind of intensive care, and they need it from their families. And if you can't deliver that, then you're not delivering the first line treatment, and that is unacceptable. It is not acceptable to care for these kids if they don't need intensive care in an intensive care unit. So we said, we're gonna stop what we were doing. If you remember, we were taking these kids from the delivery room and going to the intensive care unit. And we said, okay, what we're gonna do is we're gonna just have them go to the nursery where they stay with their mom. And we became a baby-friendly hospital, so we didn't actually have a nursery. You just stayed on the newborn nursery floor with your mom if you were a baby with us. And it actually took 18 months of negotiations to get the folks in our nursery to agree to do that. This was not a popular patient population. People did not enjoy taking care of them. They did not want to care for them if they didn't have to before. They were a little scared of the withdrawal signs. We taught them the Finnegan score. We said if they have any scores over 8, you can send the baby down to our inpatient unit. And when the mom's discharged, she will follow. And if there's another medical problem for the baby besides withdrawal, you can send them to the NICU. And so the first 6 babies that we had when we did that, they all had another medical problem and got sent to the NICU. That problem miraculously resolved when they arrived in the NICU. So it was a little bit of a protest vote. And I will come back to this because how things have changed in our nursery within a couple of years was really remarkable. So we were able to do this now. So these babies would stay with their moms, and then when the mom was discharged, they would both come down to the general inpatient unit, or the baby would come first. Now, what ended up happening within a year or so, or a year or two, is we noticed that we were not getting any babies sent down without their moms, and we went up and said, well, we're not complaining. We just want to know what's going on. We used to get a lot of babies, and their moms would follow the next day. I said, well, we saw that you guys weren't necessarily really starting medications on these kids very often, and we wanted to know. We saw how powerful it was that when the mom and baby were together, and we weren't going to break that up if you weren't going to start medication. So we wanted to keep them together, even though that meant more work for the nursing staff. And we actually recently published a paper interviewing a qualitative study in the vein of Dr. Cleveland, where we interviewed these nurses and their experience with caring for these moms, and how they really felt they were helping everybody, and how proud they were of the work they were doing. So after we did that, we actually saw more of a decrease in our length of stay, down from 13 days to 10 days. And now we're getting to where it's pretty much lower than anything else you'll see in the literature. One interesting thing that you'll notice with this is that you see the red lines actually get further apart, and there's more of these really long lengths of stay. And so what was interesting about this time is this coincided with a time of very low census in our NICU. So if the NICU got a baby with NAS, they kept them. They kept them all the way through the hospitalization. So these were babies that were never seen on the inpatient unit. And the inpatient unit, we were kind of experimenting with this on our own. The NICU didn't even know we were doing anything like this at the time that we were working on this. They just thought we were still following the protocol. So we sort of neglected to tell them that. Okay, so we're down to 10 days, and we're on a roll. So now we're having some success with this asking why, and realizing that it's really these boxes. The reason the kids went to the NICU is because it was a box. We thought that was the rule. And the reason that everyone got medications was because it was the rule. And why were we using Finnegan scores? People were mostly frustrated with the Finnegan scores, but it was the law. You had to use Finnegan. And again, if you guys showed this earlier, but some of the stuff can start to feel a little bit silly. And anytime you have things where there's a cutoff, it can feel a little silly. But you can have a kid who's had 2 scores of 8 and then has a score of 7, and they have sneezed 3 times, which we all know is totally fine, sneezing 3 times in an indeterminate period of time. But once they sneeze that 4th time, then you got to give them a point, and then they get a 3rd score of 8, and then you have to give them a dose of morphine. Except you don't give them a dose of morphine for that extra sneeze. You give them 100 doses of morphine, because you start on this very slow weaning process. And the lowest, you got to stabilize the dose for a couple of days, and then you start going down very slowly. So you're talking usually about 100 doses of morphine, if everything goes well, for that extra sneeze. And so that seemed a little bit odd to us. And then of course 8 is, and I'm sure I'm going to ask this and you can't respond, and you can tell me later if you have an answer, but how did you decide on 8 being the score? I'm assuming most of you, if you've used Finnegan, used 8, and I would ask you to think about why you chose 8. Were you in the room when it was chosen? And where that comes from. And very few people know. It's just kind of what we've always done. And I have the answer for you. Here is where it comes from. It comes from the 1975 paper. The infant with a score of 7 or less was not treated with drugs for the absence syndrome because, in our experience, he would recover rapidly with swaddling and demand feedings. Infants whose score was 8 or above were treated pharmacologically. That's it. So, in other words, they just kind of picked the number. Seemed like a good number. Hasn't really been studied further than that. It's just what people use. And it created a box. So if you had a score of 7, you wouldn't use medication. People have started to move away from that, even who are using it and taking a little more judgment into it, but that was looked at as a law, and it's really just a made-up number that has not been studied. So some of the problems with Finnegan. So first of all, when you use the Finnegan score, you have the longest lengths of stay of anything in pediatrics and use lots and lots of medications. The safety profile of these medications in newborns is not really well described, and there's some concern that they may not be all that safe. 2, the whole purpose of the treatment is to get below that threshold score. So if you can just get one fewer sneeze, or maybe you don't even, if you cannot see the sneeze, that works too, then you've succeeded. You don't have to see the baby, you don't have to interact with anybody, you just need to see the score. So one of the interesting things that really started this with me, and actually the first picture of the baby I showed was my own child, who's now a delightful 10-year-old, but was a pretty awful baby. He knows, don't worry, we told him. It was pretty miserable, and I would be standing there pacing in the middle of the night and thinking about, gosh, if he were an NAS baby and I went to the pediatrician and said, like, look, we're having a lot of trouble calming him down. What dose of phenobarbital do you want to give him? That's sort of a ridiculous thing to say, but if he were an NAS baby, we'd be like, yeah, let's load him up on medication. This will be great. We can put him down and not worry about him. We'll just sort of see if we can get him to get him sedated. So he had a lot of the signs of withdrawal, but he didn't have all of them. So he had some signs. He was irritable. He was difficult to console and things like that, but he was not hypertonic. He did not have a hyperactive Moro reflex, and he didn't have tremors. And so those 3 things are pretty specific for withdrawal. Obviously, you can have tremors and things like hypoglycemia, but they should go away when the hypoglycemia goes away. So those 3 things are very specific for withdrawal. Now, here's the question. Remember, the treatment for these babies is to try to keep them wrapped up and calm. And how do you know if a baby has a hyperactive Moro reflex? And how do you know if a baby has tremors when they're disturbed? There's no secret way to do that. You actually have to get in there and disturb them and see if they have a Moro reflex, see what their Moro reflex looks like. So you have to, at the intervals that are scheduled in your hospital, you have to go in there, and it might have a calm baby, but you have to see if you can get them to withdraw. See if you can elicit those withdrawal signs. So in other words, you have a calm baby and you have to see if you can get them upset, and you can cause their disorder to come out. So I think actually doing an accurate Finnegan score can actually be doing harm on the baby. So not a great idea. Goes against the treatment. And I know if you're a nurse who's gone through this, you've tried to figure out ways around this a lot. And kudos to you for doing that. It can also be slow to respond. So again, like I said, we're just looking at the scores. You don't really have to see the baby. And we know, if the baby's really miserable, eventually they'll get 3 scores of 8. But if you think about it a little more closely, if you have a baby who's really difficult to console, is screaming, that starts at 10 a.m. in the morning. The next score is scheduled at noon. So that score at noon is a 9. Great, we don't do anything about that. Baby's still screaming all afternoon. For us, we would do the scores every 4 hours. At 4 o'clock, next score is also a 9. So close, but we're not treating anything yet. And then the baby's still screaming all the way to 8 p.m. Now it's been 10 hours. We get another score of 9, and now we can start treating the baby. Otherwise, we haven't done anything for 10 hours. That is pretty slow to respond. And of course, as I mentioned earlier, it's a powerful and potentially harmful medication to give to treat a sneeze or a yawn. So Dr. Finnegan created a list that is it's very accurate. It is a fairly exhaustive list of all the signs of withdrawal. However, we don't necessarily care about all of them. And I've seen maybe 500 kids exposed to methadone over my career so far. Every one of them has had signs of withdrawal. I have not seen a single baby exposed to methadone who has not been hypertonic. They all have withdrawal. I concede that they are going to have withdrawal. So I do not need the Finnegan score to tell me they're having withdrawal. But do I really care? So if I know they're having withdrawal, do I really care how many times they're sneezing or yawning? Is my goal really to decrease the number of sneezes or yawns? Or maybe I can think of other withdrawal signs that aren't on there, and do I want to add them up like that? Does that really make a lot of sense? Is that we don't treat sneezes or yawns in any other disorder? So is our goal really just to get those numbers down below 8, which is just, again, a made up number and sort of a strange goal? So we said probably not. So then what do we care about? So we actually stopped using the Finnegan tool, which, when we were first starting this, would create a gasp in the audience. And we said, okay, what do we care about? And we thought, okay, well, we want these babies to be able to act like babies, to do things. If we can manage their withdrawal such that they can function like babies and do the things that babies can do, then we are successfully treating their withdrawal. However we are treating it, that is successful. And the longer you treat with medication, the longer the withdrawal goes on. So you're just extending the period of withdrawal. And so if you can manage it without medications, it's going to be over more quickly in general. So we thought, okay, what is the job description of a baby? What are we trying to get them to do? So we said, okay, well, babies are supposed to be able to eat. They're supposed to be able to sleep. And at this age, you should be able to console them. You can get colicky babies, but that's later. And babies should be able to poop and things like that, but that's not really an issue. And if anything, it's too much poop in this age group. So this is really what we said. These are the things we care about. These are the things we want to follow. And so with our, we didn't have a marketing department, so we called this Eat, Sleep, Console. Sorry, it's the best we could do. So at Yale, we took advantage of the fact that we're a part of a health system and very slow moving. So we started using the Eat, Sleep, Console approach, but we were still getting Finnegan scores because that's what it said in our protocols. So we analyzed 50 babies admitted to our inpatient unit from March 2014 to August 2015. So we had 50 babies, and we assessed them every hour using the Finnegan tool, but it did not guide management. We did not talk about it on rounds. It was buried somewhere in the chart. And then we made all our decisions based on this Eat, Sleep, Console approach. And the idea with the Eat, Sleep, Console was not so much that you got medication, it's that if you were having difficulty eating, difficulty sleeping, difficulty being consoled, then we were going to intervene in some way. And sometimes that would mean we would be increasing our non-pharmacologic interventions, and other times it would mean we would use medication. But we would just do it until we can make that thing better. Proportionate, so what we look for the proportion of infants treated with morphine versus the proportion predicted to be treated with morphine using the Finnegan approach. We looked at how often the two approaches disagreed, and the NAS scores after, the Finnegan scores after the two approaches disagreed. So in other words, if we didn't give them medication and Finnegan told us to, were they worse the next day, or were they better, or were they the same? So here's what we found. So of these 50 babies, 62% or 31 had 3 scores of 8. So they would have received morphine. Using Eat, Sleep, Console, we actually only gave 6 out of the 50 or 12% morphine. There were 78 days where we gave less morphine than Finnegan told us to. And the following day, the Finnegan scores decreased by an average of about a point, and we were decreased in 70% of the cases, despite not giving medication. There were 2 cases where we gave more morphine than Finnegan told us to. In other words, the Finnegan scores were still low, but the baby was inconsolable. So we gave, and despite giving morphine, the Finnegan scores were increased by about 2 points the next day. And there were no readmissions, no seizures, and no ICU transfers. These babies all did well, and we avoided giving morphine to 50% of them. So I think looking at big picture now, remember when we talked about our first pillar of this was that mom is medicine. If you had a baby like this, and this is of course an NAS baby, in our hospital, we would have given this kid morphine and maybe morphine and clonidine. You might give methadone. I'm not sure what you use in your institutions. And so that's kind of how we treat them. If you ever see a news, like a news story on NAS, you always see a picture of the doctor standing over a baby who's screaming like this. And so what I would ask is what you would do for this baby if it were not an NAS baby. So just imagine this were a baby who looked like that. What would you do? And it's not that complicated. You probably pick the baby up. Just throwing that out there as an idea. And so basically our second, after mom being medicine, the second one was pretend it's a baby. So do what you would do if it were a baby first. So if you have a baby who is screaming, you would probably hold the baby, try to feed the baby, do all of the normal baby things. And lo and behold, most of those tend to work. That these are babies who there's a lot going on with withdrawal, but a lot of it is really that connection to the mom, and they just need to be treated they need a lot of love from their moms and from their family, as opposed to the very little that we usually provide. So moving right along, medication dosing. So we've always gone through weaning protocols that are either going down by 10% every day or every other day. And where does that come from? You'll be surprised to learn that that is totally made up. There is some evidence in the adult world. And of course, we all know that neonates are just little adults. Not really. So this is all just made up. And there's nothing about the half-life of the drug or anything that suggests you should do it in one day. So there's nothing about the rotation of the earth that suggests that. So we started to think about what we were doing, and we would still have babies who would go to the NICU, and then they would get sent up to the floor, and they would be on morphine. And we would say, oh, well, you know, they're on morphine. We still have to go through this wean. And we realized really what was happening is in the NICU, they had almost none of the first line treatment, which was the non-pharmacologic stuff. And once they came up to the floor, we were able to give a lot of that to increase that greatly. And so if we were increasing the first line treatment, couldn't we decrease the second line treatment more quickly? So we started, instead of doing it, you know, every day or every other day, we were going down, if the baby was doing okay, up to 3 times a day. So you could get off the medication in about 3 days. And we thought that didn't make a lot of sense either. So we started to do, why were we even doing it that way? Because you have this situation often where the baby has this tough time of day, where they have one really tough period. And so does that mean that we should give them 100 doses of morphine? And so we said, well, why don't we just give them a dose and then see what happens? So I'll give you some examples. And this speaks to the eat, sleep, console method as well. So if it's 3 o'clock in the afternoon, the baby is inconsolable. It's not, we're not waiting for a scoring time. The nurse says, this kid, there's no scores in this. This is just, the other way, by the way, secretly, as long as you don't tell anybody, eat, sleep, console is sort of how we evaluate all babies, but don't tell anyone. So, so if this baby's inconsolable, the nurse comes with the team, discusses it. We go and see, oh my gosh, the mom went out for a cigarette. Let's get her back, because that's the first line treatment and we need her back. And so instead of giving medication, then we say, okay, what can we do to increase the first line treatment? Let's try to feed the baby. Let's do these things. We get the mom back. The baby's totally fine. We have intervened by increasing non-pharmacologic interventions. And it worked, and we don't need to use medications. Second scenario, same thing. The mom's going to be, she had to go out and get her methadone. She's not going to be back for a few hours. We try everything to console the baby. We try feeding, we try wrapping, we try all the things. It doesn't work. So we give a dose of morphine. 6 o'clock, the next dose of morphine would be due. The mom is back. She's holding the baby. The baby is sleeping calmly in her arms, has been feeding fine. So we don't give another dose of morphine. What would that dose of morphine be for at 6 o'clock exactly? What would we be giving it for? I'm not sure. So we don't. And if the baby was still, got better for a little while and then was inconsolable, we would give another dose. We would do the same process over and over again. So there were times where there's one time where we gave, if you had scheduled it, we would have given 8 doses and we gave 6 doses. But most often what we have found, and other studies have found, is you end up giving 1 or 2 doses total. So that's not 100 doses, it's 1 or 2 doses. So when the baby needs a dose of morphine, they get a dose of morphine, and then we reevaluate. And this saw our length of stay go down to 7 days. Staff caring for the baby. This is the last one. So this is stuff where Lisa Cleveland, who of course you guys know well and have heard from recently, was an inspiration to us. And one of her studies was interviewing, and I'm sure she talked about this, but this was really important for us, and this sort of topped off how we did this. So she went over how moms feel going through this. She interviewed a bunch of moms in San Antonio, and there was 4 major themes. Addiction is misunderstood. The moms felt guilty. They felt judged by the nursing staff. Studies of nursing staffs have shown that they say they're judging the moms. So that seems to hold up. They mistrusted the nurses. Here were some quotes, and these were kind of important for us. His nurse was like, his muscles are locking up because of his junkie mom. I didn't want to visit. I would call before, and if that nurse was there, I wouldn't even go. So again, imagine if you've had children, the idea of, first of all, visiting your newborn and then not feeling welcome to visit your newborn. And you have to, if we step back and think about what we're trying to accomplish of having this go well for the baby and the mom, this is a vulnerable population. This is a vulnerable family. And if we're doing this, we're making it harder. So we're going to leave. He's going to cry, and they're going to leave him crying because they're going to be like, you know what? His parents are jerks. And here's the last one. It's long, but it was really valuable for us and really changed how we thought about it. If you're using while you're pregnant, you have a problem, a big problem, and you need help. You obviously don't care about yourself, about anything except the drug. Make it a little bit easier on that mother if she's showing initiative. If she's taking time to be there, if she loves her child, you can see it and you can feel it. If it's obvious that she's there for a baby, then embrace it. Make it easier. You don't know what her circumstances are. You don't know what she's been through or how hard her life has been. And you don't know what she was feeling when she was pregnant. She was being abused, if she was poor, whatever the reason she was using while she was pregnant, you just don't know. So try to make it easier for her. We realized we were making it harder on these moms. We were judging them. We were not welcoming them. We were, if they did anything, little thing that we didn't think was exactly right, we were calling the Department of Family Services. And so we started to think big picture. We have these babies and these families here for, our length of stay went down for about a week, but they're going to go home together for much of their life. So how do we make this so this is going to go well and we get them ready to go home? When we started this project, when our length of stay was about 4 weeks, when we would get to discharge time, we would say, okay, you can go home tomorrow. And the family would be like, we're not ready to go home. We don't even have a crib yet. What are you talking about? And it was as if they got to pretend that they didn't have a baby for 4 weeks. And then we were going to just hand off this baby who is still withdrawing. It's not like everything's fine when you send them home. They're just they're just not that bad anymore. And so they haven't bonded at all, and you're going to go home to this vulnerable population with this baby who's screaming. It doesn't sound like a great idea. So what we said is what we want to do in the hospital is take advantage of the time they're there so we can get the moms ready and feel comfortable when they go home. So instead of us handing the baby off and then being like this, is that at about 5 days, the moms are standing at the door saying, hey, I got this. Can we go home? And the answer is yes. So really what our role became, we said how do we empower these moms? And we realized our role was really as coaches and as cheerleaders. How are we going to get them ready and make them know that they had what it took to take care of these babies? And so we started that prenatally. There are times where there is no family there, and I'm sure you guys all experience that. I'm sure people that is a question everyone has. And the answer is it doesn't change what the baby needs. It's a little bit hokey, but the treatment for these babies is really love. And if there's no family to provide it, then we as a medical system have to figure out how to provide that for the baby. The answer isn't, well, your mom can't be here, so you're going to stay for 3 weeks and we're going to give you a lot of morphine. That can't be how we do it. So we have to find other ways. We use our volunteers. We use our medical students. I watch Sports Center with them all the time. I don't get to watch it at home, so it's nice for me too. So to summarize, and we'll start to wrap up so we have time for questions. I'm running a little longer. The goal the old way we were doing this was to suppress the withdrawal. And now it's to have the infant function as a normal neonate. In the old one, the NICU, the mom visits. Here it's a mother and child together. And that is how we have different challenges in different parts of our health system, but that's where you start. You don't start with, oh, we don't allow this. Well, we don't let parents stay in the NICU. No. The first thing is the mother and child have to stay together. And so that's easy in our main hospital, but we have a hospital that just has a nursery. And if they have one extra room, if they can use that room for the baby and the mom, they stay there. If not, they come over and stay with us because the mom and baby must be together. One of our other hospitals, they figured out how to close off an area of the NICU so this family the mother can stay and they can have some privacy. There are solutions to this, but you have to start with your box being that mother and child stay together. And then also the way we talked about this over time changed quite a bit. We started by saying, okay, you're allowed to stay. And then we said, oh, we should encourage you to stay. But, when we thought about it, again, as mom as medication, we don't encourage the pharmacist to send up the antibiotics for the baby. That's not how things go. It is the treatment, and that is the job that treatment comes. It's not encouraged. So we would start this conversation early, and we would say that it's really necessary. We do this and try to do this in a supportive way, but we say like somebody needs to be here because this is the treatment for the baby. And we're not asking you to stay for 4 weeks. If you had a C-section, you'd be there for 4 days. We're asking for 5-6 days or so. Finnegan stores, treat the number. You just have to look at the number. Here we have to ask, you have to actually treat the infant and see how the infant is doing. How are they responding? I was really moved. I was up at Dartmouth in New Hampshire, where they've done a lot of great work on this and really take pride in their non-pharmacologic care and do an amazing job with it. But for a while, they were still using the Finnegan score. They've switched now. But they had a panel of these 5 moms who they thought had a really good experience with all the non-pharmacologic stuff. And the mom spoke for an hour. They spoke of nothing but the Finnegan score and how scared they were that somebody would see that yawn. And they knew that that nurse who came on tended to score higher, because they knew if they tripped over to 3 scores of 8, they just bought themselves 2 more weeks in the hospital. And so they were so focused on the signs of withdrawal in their baby that they got less focused on how just the baby was doing and whether they were managing it. So we don't talk about, we can look at some of them and say, like, here's some of the things to look for, but we're not scoring them on that. It doesn't serve any purpose. Everybody does supportive care. Everybody does non-pharmacologic care. We are zealots about it. It is the treatment for these babies. Feeding on demand, we had to get rid of this because people were still stuck. This is like something, we just don't put a timing for the feeding disorder. You feed the baby when they're hungry. And so there's no feeding schedule. They need to be fed when they're hungry. They need the calories and they need the support. Morphine was the key to our old protocol. Now it shows up somewhere on page 3. It was often a surprise to families about what was going to happen in the hospital, and now we prepare them prenatally. And the staff job is to take care of the infant. Now it is to coach the parents and support them. How can we help you? And how do we support you in give you the same, this is our 3rd pillar. So one was mom is medication. Second one is pretend it's a baby. And the 3rd is treat the mom with the same respect you would treat any other mom. How do you support her? So our length of stay for the last, and this is, I only have it out through a couple of years ago, but it's stayed consistently just below 6 days over the last 5 years. We've also moved this to the other hospitals within our system that have other challenges, and they all have lengths of stay of 6 days or less. And again, not really our goal. It's almost that was a side effect. So this is an extension of the graph I showed you earlier. We treated 98% of our babies when we started this. We now treat 100% of them aggressively from birth. We treat them aggressively with non-pharmacologic interventions. We just don't use medication very often. And we're somewhere around 10 to 15%. I actually think we're a little bit lower than we should be. We've gotten, people don't really think of it as a treatment option. There should be more freedom to use a dose or 2 of morphine here or there, because you're not buying a whole course of morphine. You're just buying that 1 dose. So I think probably the right number is somewhere around 20 or 25%. That's just an estimate by me. And we also found that we've gone up above, in the last 6 years, we've gone above our starting dose of morphine twice. And people ask me, how do you do that? We're like, we just kind of figure it out when it happens. We just go up a little bit because it's not something we're used to. And we don't wean off of that. We give the doses as needed. Breastfeeding rates initially went up to above 50%. We have struggled on this in the last couple of years where it's dropped quite a bit. And that's more of a side effect of some of the responses to marijuana and things like that and the advice given on that. But we had no breastfeeding, and now we've encouraged it quite a bit. Our cost of care went down by 75%, which the suits like. Boston Medical Center started to do what we did, and you'll hear from Dr. Wachman, who has done an incredible job and has adopted and adapted this in a much more difficult environment. So if you're looking for how to actually, we kind of developed it over a long period of time, and that's not the way you want to do it. She put this in a really challenging environment very, very successfully. So I'm looking forward to you guys hearing from her. So they had been using the Finnegan approach, and they started to kind of change how they use the Finnegan score, started to just pay attention to parts of it. And then they actually developed the Eat, Sleep, Console approach to scoring tool. I don't think that's actually necessary, and I think there's probably some negatives to that. And they've been using that in December 2016. So the scoring tool sort of like, there's not much to it. And there's actually working with Dartmouth, there's a much more complicated version of this tool, which I also think isn't such a great idea that a lot of people use. If you feel like you absolutely need a tool, then you can use that. I think it actually can have a negative because you end up just looking at the baby at those times as opposed to whenever the baby's inconsolable, and you start to focus on it a little too much. So for Boston Medical Center, they decreased their rates of morphine from 82% to 40%, and their length of stay from 18 days to 10 days. And they had no readmissions. They were not satisfied with this, so they actually brought their team down to visit with us to find out what they were doing differently. And then went back up, and they recently published one of the papers on here. They started using the approach of the as-needed medication, and their length of stay has dropped down below 10 days now. There have been a number of papers using this over the last year or so from around the country, from New Mexico and North Carolina and Oregon and Boston and Missouri. So all over the place have had lots of success with this model. So there's lots of references in different types of settings, community and academic. There's also been spread, it's hard to keep track of this exactly. No one's done a study on this of who's using what, but reports I get from places, it's at least in about 30 or 35 states at this point. And the real question that comes from this that we will start to get answers to in the next few years is, what are the long-term outcomes if we use this kind of management approach versus a traditional Finnegan approach? We don't really have the answers for what it looks like in a traditional Finnegan approach either, but just understanding the long-term outcomes for NAS in general and whether this has any impact, positive or negative, we don't know the answers to that yet. So to summarize, the idea here, it's hugs before drugs, basically. It's empowering families, it's rooming in, it's non-farm care as the first line treatment. It's using this eat, sleep, console approach, not the scoring tool, but the approach, which includes all of this, and as needed medications. And the three tenets of this to keep in mind: mom is antibiotics. Pretend she's antibiotics, build your system with that in mind. Pretend it's a baby. Do all the things you would do for a baby to console a baby and see if those things work. And then treat the mom with the same respect that you would any other mom. And then ask why. There's more of these things in pediatrics. Ask why you're doing what you're doing and make sure there's a good reason. If you're not allowed, we say, well, we don't allow overnight stays there, or we don't use morphine on this unit. Well, why not? Is that just a rule somebody made? Is there a real reason for it? Is there really no way to do that? And start to challenge those things, and you'll find that some of these things have pretty flimsy basis to them. And I think we have a little bit of time left for questions. So
I'm going to extend the questions about 5 minutes since we started a little bit late.
Works for me.
But we do have, if you want to start typing in your questions via the chat. I do have 2 questions from Veronica. The first question is who was doing the consoling in the study, nurses or mothers?
Anybody. So it was mostly mothers. So the mothers were there, it was them, but we were equal opportunity. So it could be any family member, a mother, a father. And if they weren't there, we used our nurses, our volunteers, our doctors, our residents. It's sort of, we always say it takes a village for that one. So it doesn't, ideally it's the mom, but if she's not there, we look for anybody else.
Okay, Veronica's second question is how has the new protocol been affected by COVID-19 measures?
It hasn't really. So we have, for us at least, so we were hit fairly hard. It has not hit pediatrics all that hard. We've had some positive moms. We haven't had any positive moms with babies going through withdrawal, and we're not exactly sure how that depends on it. There's a couple of contingencies, but we have moms and babies are still together in our hospital even when COVID was raging. We test all the moms. But it affects our ability to have other people help out. So it's more important that a family member is there because we don't have volunteers right now, and we don't have medical students, and we have fewer people. So it's much more important that we get somebody to stay with the baby. And so far we've had success with that. But it'll be if we don't have somebody who can stay, it'll be more of a problem. And we'll have to sort of rally around the core team that we have and figure out how to console the baby as best we can. But it won't go as well.
Okay, so we have a question from Tashley. When the child is sent home, are they sent with any medications?
No. So we use no, definitely not. So we're not using, if you saw, we're using about 10 to 20% of the kids are getting any medication at all, and it's very rare to get more than 2 doses. So we do not and never have sent kids home on medication. If you're using this method, there's no room for sending home on medication, really. We're sending home with a lot of first line treatment. So if you still need second line treatment, we're going to keep you in the hospital.
All right, we have a question from Lindsay. She says, can you talk more about the marijuana protocol's impact on breastfeeding in your facility?
Yeah, so this is not something that I had a role in as we, and I think we're finally adjusting. We had a pretty restrictive breastfeeding policy around marijuana. So if there was any positive marijuana, then moms were discouraged from breastfeeding in the hospital. So I don't know that, and that was based on a study that came out from Colorado a couple of years ago. So so we're re-looking at that, and we'd like to try to loosen it up a little bit if possible. But that's really what changed kind of plummeted our numbers.
All right, I'm waiting for a few more to come in here. Any more questions from the audience? If you want to type it on the chat. Oh, here we go. This is from Maria. Where are the comfort rooms for NAS babies located? What states? I'm in Texas.
So the comfort room. So there aren't comfort. It's just a regular hospital room for us. So it's just any place where we can have the mom and baby together. So there's no specific room. We would, in the community hospital, they built temporary walls to give them some privacy and give the mom a chance to stay. But there aren't special rooms. We don't have special units. They just come to our general pediatric unit. They often end up because we have a lot of double rooms. A lot of NAS babies end up rooming in together. So there's usually 2 families in a room, which isn't ideal, but sometimes it actually works out pretty well. But there are no special rooms. It's just mom and baby together, figure out that problem. How do you in your hospital make that happen? So some people have different rooms or built different areas or repurposed some rooms so that can happen. So that's kind of the issue with that.
Got one from Catherine. She says, or this might be a comment. Thanks. Have loved the approach in our institution. Let's see. Have loved this approach in our institution since August 2019. No babies needing medication so far. Non-pharmacologic care all the way.
Yeah, and the one thing I would say is I think we have sometimes flipped a little too far with not using medications, and we want to make sure that we're not using that as too much of a badge of honor that we haven't used medication. If we don't need it, great. I have found it's very strange and going through this is that there's times where I'm saying like, look, or it's saying, this baby's difficult to console right now and might need a little more support, and it's okay to give it. It's okay. It's not a failure to give a dose of morphine. It's not really going to extend the time in the hospital that much. It tends to be on day 3 or 4, and then we usually give it a day after the dose, and then you can still go home within 5, 6, or 7 days.
Okay, we have a comment or a question from Jennifer. How is the protocol different when drugs other than methadone only are involved? For example, if mother isn't involved in methadone program.
Yeah, so again, the data we used was methadone just because we knew it was going to be our most consistent withdrawals. The protocol is the same, or it's not our approach is the same no matter what. The only thing that might be different is if we use medications and there's a big benzodiazepine component, we might give Ativan as a medication before we would give an opioid. That's the only difference. It doesn't matter. The rest of it does not matter. And the other thing I would say, about that is with well, I lost my train of thought there. I'm sorry. Let me share another story before and hopefully I'll come back to that one. With the one hospital I mentioned in the beginning that I gave my first talk to was Middlesex Hospital, and they were 45 minutes up the road, and they recontacted us, and their length of stay was still about 4 weeks, and they just talking about how you do some interventions with this. They came and spent the afternoon with us. We went over everything. We met some families, and on their drive back up the highway, their 45-minute drive back, they completely changed how they approached their babies with NAS starting that night. One of the people who came was on that night. They said, there's no way that we are treating moms and babies the way we've been doing it for one more day. That is not the way. Most places are going to take a little more time getting into it. But there's also places that take way too long. They say, okay, we're going to make this one small change, and then 2 years later, we'll make another one. They did it that night. It was a tough 3 weeks, And then everyone was totally on board, and they have not had their length of stay is below 10 days since that night.
Okay, we have a question from Lindsay. Do you see the Eat, Sleep, Console protocol becoming more popular across the country, or is there significant resistance to change?
So it's definitely, you read these articles that say how long does it take change to actually go into places, and it's 17 years. We have definitely seen lots and lots of places that are using this. We don't have a number for it yet, because there's just, whoever, as Maria reported, or whoever, that they're using it in their, Catherine, that they're using it in their hospital. We don't have any way to track that. So we know that it's being used in lots of places. I think most places aren't using it still, and there is a resistance to it. It's a big change. There's some issues. If your NICU volume is built around this, and we're saying if you do this, we could probably cut your length of stay by 2/3. That is a big business model change. People have been doing it the same way for a long time. So change is hard, is what I would say. It's hard to argue that much against the approach. Most people don't want to be on the side of keeping moms away from babies. So that part is hard to argue with. I think it's a pretty common sense and pretty, it's hard. Those mother-centered approaches are harder to argue with, I think. One of the things, I can remember the point I wanted to make before. So there are certainly moms who are not going to take their kids home. And we know that our Child Protective Services, who, by the way, has taken away far fewer babies since we started this, we know that's going to happen. We also know that's not always permanent, and often isn't permanent. And at least in our state, with very rare exceptions, our Child Protective Services does not make their custody decision until the end of our hospitalization. So we, regardless of what's going to happen, we get to use those first 5 or 6 days and have the mom and baby bond. It's both great treatment for the baby, and it's this bonding that they can't get any other time. And if they're going to be reunited, they have that. And so we take advantage of that. So there's no different approach, regardless of the drugs, and really regardless of what the disposition is going to be, unless we / the Department of the Protective Services is concerned about the well-being of the baby in the presence of the mom, which again doesn't happen very often.
All right, we have a question from Veronica. How do you train the hospital staff to use the Eat, Sleep, Console?
That's a good question. It's been a while since we've had to really do it, but we kind of go over the why we go. I kind of give them this talk and explain why, or a version of this, of why we're doing it and where this came from, and then a focus on some of the non-pharmacologic care. There is the folks at Dartmouth and Alicia might talk about this, built they built like a training pathway with it, but it's mostly kind of common sense things, and how do you soothe the baby, and it's really a lot of it's trial and error. What works best to soothe this baby? How do I try to feed and doing those kinds of things? And just, it's really a focus on how are we supporting this family and coaching them and helping them so that they are going to be confident in taking care of their baby, because they are going home with this baby, and we want this to go well at home. And so it doesn't take much training, because a lot of it, there's nothing that people don't know. It's just making sure that we have that mindset and that approach in what we're trying to accomplish. So we don't even really do anything formal for our new nurses. It's just that the old nurses, not the old nurses, the nurses the more experienced nurses just sort of chat about it a little bit.
All right, we have 2 more questions. The first one is, can the kangaroo care approach be used for NAS babies?
Definitely, yeah.
Okay.
That works very well. Yeah, so it's all the holding. So you have to see whether some babies really respond to being swaddled more often, but most of the time the kangaroo care works awesome, and skin to skin, and we're able to do all of those things very well, and those work great. So yes, more of that.
All right, and then we have Veronica has 2 questions. Hers is, will Eat, Sleep, Console protocol be successful with infants whose moms are not in any methadone treatment program?
So one way to I can answer that with a question. So would we say, okay, so with moms who are in a methadone program, which again is what we've studied, we've done this on everybody, and I kind of wish we just include everybody because this I shouldn't get this. I know this question, it can be confusing, but so would you say if you're not in a methadone program, should we take the baby and put them in a bassinet and have nobody hold them? So no, I think this is for any baby who's going through withdrawal. It should also make us look at what we're doing with babies who aren't going through withdrawal. They're being separated from their moms. We better have a really good reason for doing that. There's stuff in your state, nearby with border stuff and about separating families. We don't want to be doing that in the hospital if we really, really don't need to. So it doesn't matter what the exposure is. We are going to use this same approach. We are going to have, it's a mother-centered approach. We try to do that with all of our babies, and definitely with all of our babies with any withdrawal of any kind. So methadone has nothing to do with it. Methadone is just use those babies to show our results, because those are going to be the worst ones. But if it's heroin, if it's buprenorphine, if it's whatever it is, mom's exposed to, we're going to use that same approach, as should you. It shouldn't be any different regardless of the exposure.
Okay, the last question, you may have answered a little bit of it, what you just said, but it's, have they used the Eat, Sleep, Console protocol on moms on multiple SSRI or anti-anxiety meds rather than opiates, and how did this population do?
Yeah, so we don't, this is the idea that, you can think about what you would advise a mom, because they don't get kind of included in that population, but you say like, yeah, this baby might be more irritable. You should probably hold them more and do those kinds of things. So we would do the same approach. We wouldn't use more, if you're going to use an opioid medication, that treats opioid withdrawal. It does not treat other kinds of withdrawal. So that's what we see oftentimes with babies who are going through benzo withdrawals. They're getting more and more morphine, and it's not helping because it's benzo withdrawal, and morphine doesn't treat that. So we would do the same thing, and we just wouldn't use medication.
All right, that was the last question. Dr. Grossman, would you be able to share your PowerPoint or a version of your PowerPoint that we could put online for everybody to look at in case they got disconnected and came back on or something like that?
Absolutely.
All right, well, we really thank you. We're already getting the thank yous coming in, and we appreciate you taking your time and helping us support NAS Awareness Month in Texas, and helping all these folks learn about it. So thank you so much.
Thank you, and everybody stay safe, please.
All right, bye.
Bye.